Michelle Haw, thank you for joining us. I'm looking forward to your panel presentation later on.
Thank you. Should I wait and join at 4:30?
No, you're welcome to be a part of this conversation.
Okay, thanks.
That's true. I forgot for a brief moment that we have presenters that are scheduled at a certain time. I don't know how that interferes with them or affects them if we start it now.
Right. I don't know if our panelists, I know that we gave them a specific time on the agenda, so that could affect things. And the same thing as well with attorneys joining us for the executive session at 6:20.
Our meetings always run over.
Okay, I know Rosanna is not going to be able to join us till 4:30, and I see that there are 5 board members with us. So I'm going to call the meeting to order. It is 4:01. And Renee, could you do the roll call, please?
Yes, please state present after your name is called. Representing Adams County on the Board of Health, Julie Mollica.
Present.
Rosanna Reyes, and as you noted, Kaya, she will be joining us later. Julie Schills.
Present.
Representing Adams County, Arapaho County on the Board of Health, Jan Brainerd.
Present.
Dr. Thomas Faywell.
Present.
Dr. Kaya Gallagher.
Present.
Tri-County Health Department Leadership, Michelle Askenazi, Director of Emergency Preparedness, Response, and Communicable Disease Surveillance.
Present.
Heather Baumgartner, Director of Community Health Promotion.
Present.
Lisa Bolstad, Administrative Assistant.
Present.
Jill Bonchensky, Director of Nutrition.
Present.
Renee Brockman, Executive Assistant. Monique Didier, Director of Administration and Finance.
Present.
Dr. John Douglas, Executive Director.
Present.
Maine Furman, Director of Human Resources.
Present.
Penny Grandy, Director of Nursing.
Present.
Brian Halavisek, Director of Environmental Health.
Present.
Jennifer Ludwig, Deputy Director.
Present.
And Dr. Kelly Weidenbach, Director of Planning and Information Management.
Present.
Roll call is now complete.
Thank you. Usually we have the Tri-County team introduce those who will be attending the meeting, but I'm wondering, Renee, if we should postpone that till 4:30. What do you think?
No, I will go ahead and leave that up to you. As I stated, we don't have anybody who has signed up to speak at the public hearing, so we can go ahead and ask for volunteers if you would like, if anybody would like to speak, or if we can go ahead and do introductions of staff, but that's entirely up to you.
Okay, why don't we do introductions of staff? Is there anybody from the Tri-County team that would like to introduce those who are attending our meeting tonight? Yes, Michelle.
I just wanted to introduce, I know you've met her before, but just as you get to know her further, Alex Kellogg, and she's our COVID-19 Partnerships and Strategies Program Manager, overseeing our partnerships and strategies work, both in vaccine and testing.
Welcome. Great. I know, Heather, you have a group here.
Thank you. Yeah, I'd like to introduce Michelle Hawk, our Workplace Prevention and Equity Lead, and also Patty Corcoran, our Community Health Promotions Operations Lead, who are presenting the panel later on.
Terrific. Not seeing anybody else right now. So the Board of Health members, just as a reminder, if you'd like to make a comment, please use the chat function or raise your hand. And to start our meeting, we have scheduled a 30-minute public comment period. While the Board of Health members have received literally hundreds of emails from local residents, we had a request to allow time for a public comment as part of our meeting. So today's citizen comment period will last for 30 minutes. We're giving each speaker 2 minutes to speak. We would ask prior to speaking that each speaker state your name and provide your address. We will be listening to comments but not responding. Those who do not have an opportunity to speak or have other comments they'd like to make are welcome to use the Q&A function as part of Zoom. And as we have done in the past, all the comments that are provided during tonight's meeting will be compiled and shared with the Board of Health after the meeting. Anyone who has questions or is seeking additional information can also go to the Tri-County website, where there is up-to-date information as well as contact information for the Tri-County staff. So this was a request that we try the public health comment period. Rene, could you confirm whether anybody has signed up?
Nobody signed up on registration. Would you like me to ask if anybody in the audience would like to raise their hand and speak, or?
Yes, that would be a good way to go.
Okay, so if there's anybody in the audience who would like to address the board about any topic for 2 minutes, please go ahead and raise your hand. And I will go ahead and promote you to a panelist so that you can address the board. And I am not seeing anyone. Looking through the list of individuals present, it appears that everybody here is Tri-County staff with the exception of one person.
Okay, great. Well, would any Tri-County staff like to make a comment?
And once again, no hands are raised.
Well, Kaya, my comment would be that I know that our panelists, who we really are appreciative of joining us, might not have planned to be here so soon. So if it could help, I could do my presentation out of order. So just as a way of dealing with the our invited guests and their time.
Well, that's a great offer, but unfortunately, Rosanna can't join us until 4:30. So I can't move items up until the actual meeting time that we had scheduled previously. Julie, Malika, did you not have a proposal that if we had nobody who wished to speak, that we actually take a break and that we come back at 4:30? Is that what seems to be reasonable?
Yep, yes. Since you're chairing this meeting, you're welcome to take a break and let us come back at a designated time if you'd like.
Okay, thank you. Well, this we did have a request to give this a try, and here we are. As I said, we welcome comments from people in our region. We have received many emails before, during, and after our meetings. People are welcome to use the Q&A function to make comments during our meeting. And at this point, then, I would propose we take a break until 4:30 when we begin our meeting, the official items that are listed on our schedule. So thank you very much for showing up at 4 o'clock.
Oh, yeah. So
So it is 4:30. Renee, did you need to do the roll call again?
No, I shouldn't.
Okay, it looks like Rosanna has joined us. We will then move on to the action items. First of all, welcome everyone. As the first action item on our agenda, do I have a motion to approve the minutes from January 13th?
So moved.
Is there a second? All in, any discussion? All in favor say aye.
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 Anyone opposed? Thank you. The motion carries. Secondly, do I have a motion to carry them to approve the minutes from January 31st?
So moved.
Is there a second?
Second.
Any discussion? All in favor, please say aye.
Aye.
Anyone opposed?
Aye.
Thank you. Thank you. Motion carries. So tonight, the Board of Health, the first information item is a panel of speakers on the Creating an Equitable Workplaces pilot program. I'm not sure, Michelle, that we had a chance to get to know all of the panelists who are going to be speaking tonight. Did you want to introduce the panel before we begin?
I can get started and then we'll introduce to give everyone a chance to get on at the point that they come on. Does that sound okay?
That sounds great.
All right, terrific. Thank you. And I'm going to go ahead and share my screen. Can you all see my slide? Yes, okay, terrific. Thank you. Well, good afternoon, members of the board. And I don't know if any community members are on now, but hello to you. And of course, to my Tri-County colleagues. Just want to thank you for the opportunity to present today on the Equitable Workplaces pilot. My co-presenters include Patty Corcoran, who's in our Community Health Promotion Division, as am I, Tanisha Dubose, who's in Human Resources Division. And then we have the pleasure of hearing from 3 of organizations that participated in the pilot. We'll hear from Amy Alarcon of Christian Living Communities and Capella Living Solutions, Katie Goldman from La Victoria Healing Kitchen, and Lorena Toland from Food Bank of the Rockies.
Michelle, excuse me, can you change to presenter mode? We are seeing your presenter notes on the screen.
Appreciate the heads up.
Thank you.
Are we good now?
Yes.
Thanks. All right. Okay, so here's a quick outline of what we'll be presenting today. I'll give you a little background on how we started working with employers, and I'll review basic components of the pilot. Tanisha will review the organizational assessment tool, and Patty will share the evaluation outcomes. And then we'll have our employers share their perspective, and then we'll be open for Q&A. So this is a timeline of our work with employers. Starting in 2012, we've been supporting local employers in the workplace wellness field. And we've actually received 2 NACCHO Model Practice Awards for that work. In 2015, we were awarded funding through CDPHE's Cancer, Cardiovascular, and Chronic Disease Grants Program to expand our efforts. And with that, we organized 5 employer coalitions with 80 organizations representing over 100,000 employees. And this work has involved connecting employers with each other and with best practices for implementing workplace wellness policies, systems, and environmental changes. 2 areas of focus for us have been healthy food and beverage, environmental changes, and improved access, and also creating lactation policies and walking employers through the process of getting the statewide breastfeeding friendly recognition. In the summer of 2020, following the tragic murder of George Floyd and ensuing worldwide protests, many companies were making public statements against racism and pledging to engage in diversity, equity, and inclusion work within their organizations. And the employers in our network were very eager to do this work. They wanted to learn more about diversity, equity, inclusion, best practices, and so on. So we organized a couple of learning opportunities. We partnered with Kaiser Permanente to do a panel called Why Is It So Hard to Talk About Race? And then we also co-hosted a webinar called How to Become an Anti-Racist Organization with one of our other partners, HealthLinks. And both of these learning sessions were very well received by our employers. And we realized, though, that they needed a little more support rather than just, a couple of one-off webinars. So we invited some partners to the table, Maker Housing, American Heart Association, and HR Choice, to talk about some sort of sustainable program that we could provide to employers. And after 6 months of planning, we launched the DEI pilot, which we called Equitable Workplaces Pilot. And similar to the initiative, it's based on a peer support model. And towards the end of the pilot, November, we were able to hire a third-party evaluator to evaluate the program, and the findings were very encouraging. And we're now seeking funding to expand this program. So now that I filled you in on the backstory, I'll provide a brief overview of the pilot itself. These are our participating organizations, 13 organizations, and you can see they are from very different types of industries, or they represent different industries: government, nonprofit, and for-profit. Each of them were at a different starting point in terms of their DEI journey, if you will, and they all had different, capacities. Some actually had a designated work DEI manager, and some were running on a volunteer, DEI employee committee. And some were just one person really wanting to champion this for this organization. So it was very different as far as they were concerned. The components included monthly sessions for 90 minutes. And during these sessions, we had confidential peer sharing and problem solving. Sometimes we had some expert presenters, and there was homework assignments that they would complete and then share at the following meeting. The whole program was based on the assessment planning tool, which included 5 areas of focus, or domains as we call them. And these are the domains that were covered. This was basically our curriculum. And you'll see in the middle of this diagram is change management, because change management principles we found were crucial to implementing any strategies in any of these domain areas. I'm going to hand it over to Tanisha now. She's going to give you a little more information about the domain areas in the context of the organizational assessment tool. Tanisha?
Thanks, Michelle. So at the beginning of the cohort sessions, we introduced the DEI organizational assessment tool. The organizations go through and rate a series of indicators for 5 domains, the ones that Michelle just mentioned, that reflect diversity, equity, and inclusion practices using a 1 through 5 rating scale. We ask each organization to really take time to honestly complete the assessment. The goal when completing the assessment tool is to leverage knowledge of current practices from individuals at multiple levels to get a clear idea of how the organization is doing as a whole in their DEI journey. Next slide. The 5 domains of focus are planning and policy, organizational culture, employee education and training, HR policy and infrastructure, and community capacity building. Under each domain, you will find several indicators to be scored. Each score should be justified with examples of how the organization is fulfilling that particular indicator. Next slide. Just to give you all an example, if we go to the employee education and training domain, which is outlined on the slide, the first indicator states our organization requires all staff from all levels of the organization to complete education and training related to diversity, equity, and inclusion. So as you can see here on this slide, would be where the indicators would lie. There's several that land under each of the different focus areas. And then the organization would then provide an example here in this yellow box. For instance, TCHD could currently provide a scoring of a 4 on this indicator based on the efforts that have gone into providing education and training for our staff on health, equity, and racial justice. We would be able to increase our scoring to a 5 if we expanded education and training to include our Board of Health members. Next slide. So once the assessment has been completed to the best of the organization's ability, they will receive a score average for each domain on the scoring tab. This section of the tool will help the organization understand how well they are performing DEI across the 5 domains. By identifying strengths and improvement areas, organizations now have a clear baseline for their DEI efforts. So on the slide, you can see that would be how the scoring tab would look for our organizations as they've input for each of the domains. Here is where you'd be able to interpret what those different numbers mean. So for instance, an interpretation of an average score of a 1 would mean that substantial work is needed to be done in order for them to meet the marks for an equitable and inclusive and diverse workplace in that area. And then a 5 means that you are hitting all marks for the organization for an equitable and inclusive and diverse workplace for that particular focus area. And then as you can see down here, since we did plug in like a 4 for our employee education and training, it shows that, and that would be similar for all of the other domains as well. Next slide. So the final section of the tool serves as an action planning guide to prioritize areas that require improvement for the organization. Oftentimes, the most challenging aspect of this work is the action, getting started or staying motivated to follow it through. So this tool can essentially help drive and unify plans to advance diversity, equity, and inclusion across an organization. So that kind of puts into scope the assessment tool. So I will hand it over to Patty now, who's going to share our pilot evaluation results.
Thanks, Tanisha. We were able to hire a consultant called New Summit to evaluate both the curriculum and effectiveness of the pilot. Our evaluator is an educator and DEI business consultant. We got high praise from our participants and also high marks from the evaluator. Some of their findings were that this program is highly effective in encouraging organizational DEI progress in ways that support employees and community members, that the curriculum is comprehensive and based on sound research and instructional design, and the content and structure support organizations to create a roadmap and implement thoughtful and effective action steps. Their recommendation was to continue and expand the Equitable Workplaces program. We don't know of any other program like ours is comprehensive, interactive, and action-based that is also free for participants. Having this resource come from the Public Health Department is a huge benefit and service to our communities, and it directly addresses the recent acknowledgement that racism and health inequities are a public health crisis. Next slide, please. Thank you. Now we'll begin our panel presentations. First up is Amy Alarcon from Christian Living Communities and Capella Living Solutions. This organization wins for highest participation. Christian Living Communities has been a committed participant in Tri-County's Workplace Wellness Initiative since it started in 2015. They were one of the first employers to join the DEI pilot in 2021, and I don't think they've missed any of the monthly sessions. In fact, they typically have 2 to 3 representatives attend each session, one of whom is a member of their board of directors. So I'll turn it over to Amy now.
Thank you. Good evening. As Patty said, my name is Amy Alarcon and I'm with CLC Capella. We're a senior living organization that was founded almost 50 years ago in the Denver area. And we now have 13 senior living communities, and this work on the pilot impacted about 650 of our employees. So thank you for the opportunity to share my experience with the Equitable Workplaces pilot with you. Going through the pilot in 2021 was invaluable for many reasons, but 2 key areas really stand out. First, the DEI organizational assessment that Tanisha highlighted was great because it allowed us to objectively assess where we were at. We found we were already doing a lot of things well, but we didn't have a concrete structured plan in place. And so this really helped us figure out where we needed to go to be where we wanted to be and to be truly a leader in this area. And so it provided good information and discussion for what we needed to do next. The other aspect of this program that was truly invaluable was the idea sharing amongst the participants. A DEI is big and it can seem really daunting. And there's so many aspects to it that hearing from the other participants helped us to narrow our scope a little bit. And then it was also helpful to hear from those outside of our industry, whether to just hear that they had the similar challenges that we had, or also to hear their great ideas and to share ideas across industry. There were many takeaways through the sharing process, but one that really stands out to me is around recruitment. As you're probably aware, recruiting right now in today's job market is very challenging. And so hearing what others were doing to attract the diverse workforce was very helpful. And then that led us to look at our own recruitment practices and change the way we posted our job descriptions to try to encourage all applicants to apply, and how to support our leaders in talking about equity in our workplace, and then also looking at our overall strategy as an organization. So it was really rewarding to see these ideas take hold and really make an immediate impact on our organization. Next slide, please. The pilot helped us to create a comprehensive formal DE&I plan for 2022. It includes a communication strategy, training for our leaders and our board of directors, as well as making it part of our strategic goals. And because of the great work that we did last year, we were able to get money in our budget this year for a DEI consultant, which is huge. It's going to be so helpful in moving us forward as an organization. And it's also part of our organizational commitment of creating community. We really want to be that workplace where everyone belongs. And then the other key success I'd like to share is that we really found, and through this work in 2021, that our employees wanted a way to learn more about DE&I and share their ideas and have some discussion. And so we're implementing learning circles throughout our communities with a video or speaker, and then just a guided discussion afterwards. And our first one kicks off next week, so there's a lot of excitement around that. Our employees are looking forward to learning more and being able to share their own thoughts. So overall, our time with the Equitable Workplaces pilot was time well spent. It was invaluable to our organization to further strengthen our commitment to diversity, equity, and inclusion. So we're very thankful that we had the opportunity to participate, and I thank you for your time this afternoon.
Patty, can't hear you.
Oh, sorry. Thanks, Amy. Those are some great initiatives you've been able to start, so congratulations on that. Next up, we have Katie Goldman, owner and creative director of La Victoria Healing Kitchen. Katie's organization is unique to our cohort because she joined before she had any employees. This enabled her to incorporate DEI principles into her business plan, or as they say, bake them in. So it's all yours, Katie.
Thank you, Patty. I also would like to thank Michelle and Patty and Tanisha for asking me to be here tonight. It's quite an honor to be the solo startup entrepreneur in the cohort. I'm really happy to be here tonight in front of you all. La Victoria Healing Kitchen is going to be opening this year in Old Aurora, right behind the Martin Luther King Library. I hope you all come and check it out at some point. It is comprised, it's a container. I'm building a container comprised of 3 pieces, all centered around the culinary and healing arts. One piece of that is an instructional kitchen space that also serves as private event space. Another piece is shared commercial kitchen space to help elevate like-minded chefs, makers, and bakers who want to provide healing through their products, and also providing business development and incubation services to those in the food service industry. It's something I'm extremely passionate about, as the food service industry is one of the very few in our culture that does not have as many restrictive barriers to it to let people grow and provide economic stability for themselves. I joined this program, if you can flip it to the next slide for me. As they mentioned, I don't have any employees right now. My plan is to add 3 to 5 full-time employees and anywhere from 10 to 20 part-time or contract employees based upon the programming and the workshops and classes that will be held within the instructional space. I joined the program mostly because I wanted to connect with like-minded business owners. And I also wanted to really create a strong relationship with Tri-County Health. Being in the food service industry, it was extremely important to me to not only have a good connection with environmental health, but with all of the services that Tri-County Health offers, because it's very connected to what my mission and vision of this business model is. I wanted to be able to incorporate learnings into my strategic plan. I wrote my strategic plan by the time I joined the cohort, but I wanted to be able to understand how to transition that into actual processes and procedures. And then I also just wanted to learn best practices from other businesses, stepping into a new role here. Next slide, please. I can tell you without fail, all of my goals going into this program were met, and my expectations were far exceeded. I immediately was like, additional value that was created for me was I now have a very deep understanding of the topic of diversity, equity, inclusion, and I garnered that through meaningful and tangible conversations with my cohort panel. I couldn't always relate to all of the homework and the things that happened because I didn't have employees, but I was always able to connect to what they were doing and make myself provide actionable items for the future. It helped change my perspective and my approach in the way I talked about my business. I learned that there's strength in letting my guard down and talking vulnerable from my point of privilege in trying to do something better for others. I now have access to a massive library of tools and resources that are going to help me turn my plans into actual things. And it was also really interesting to learn how to reprioritize my tasks. As I start to open the doors, there are certain things that need to happen first, and then the domino effect. And I thought I had an idea of that, and I actually reorganized and rearranged everything as a result of this program. Next slide, please. The immediate results for me were that I, as I mentioned, improved my establishing community relationships and revised the way I communicate about the business. That has been a huge component as I've become more aware of the other organizations doing great things in this area, and letting them learn how to trust me and to also garner trust from them. I reevaluated the planning of the kitchen space and the actual equipment that I specified. So a quick story on that. I was already in for permitting for both health and building permits, and I realized that the equipment I was speccing was not as accessible and inclusive and equitable as it could be. And so I went out and I respec'd my equipment so that it had more visual controls, and so that there wasn't necessarily a language barrier. And I had worked in tandem very closely with Michelle and Patty and people in environmental health and the inspectors and the Aurora, and we changed it, and it was a really great success, and I'm very excited about that. I also identified new goals for the kitchen and for the success of the business. In the future, what I'm walking away from is I now have a framework to establish and execute operational procedures with, and I realize the importance of the creation of data sets to confirm the execution of what's happening in the kitchen, inform future changes that need to happen. And I've set a new goal that I'm really excited about. I'm going to be building a case study around the kitchen, and looking forward to sharing those results back with Tri-County, with Patty and Michelle and Tanisha and whoever else wants to hear me talk about it. And the most important result for me is my last slide, and that is accountability. I, as a small business owner, just me doing this right now, I can change what I want to hold myself accountable to at any point, but now I can't. I now have a deeper understanding of what this means to the community and to the success of my building, of my business. Sorry, it's a building right now, so I say that a lot. But I now have a group of trusted advisors to help guide me and hold me responsible to the things coming out of my mouth and the actions that are actually happening too. So thank you all for your time.
Thank you, Katie. We're looking forward to your opening day. Our final panelist is Lorena Toland from Food Bank of the Rockies, the largest hunger relief organization in the Rocky Mountain region. providing over 1.5 million meals every week. Their impact is substantial and far-reaching, working with 180 employees plus 18,000 volunteers in the course of a year. They have participated in our Workplace Wellness Initiative for 5 years, and we're very eager to join the pilot when it launched. Lorena was unable to attend tonight, so she recorded her presentation, which we'll play for you now.
Can you see the slide? Okay.
Yes.
Thank you. Start at the beginning.
Hi, I'm Lorena Tolan, Vice President of People and Culture with Food Bank of the Rockies. Thank you for the opportunity to share the importance and impact the Equitable Workplaces pilot had on the organizations who participated. The framework of the pilot was well structured and was a good guide in itself to help structure our DEI committee's framework. The assessment was a wonderful tool to help identify starting points and really evaluate where we were as an organization and have a way to measure some of our success. The space created for like-minded organizations to meet, engage in dialogue, share best practices, and provide support was invaluable. The resource and connections that were made were of great value. At Food Bank of the Rockies, we completed the organizational assessment and created organizational roadmap and have set goals and initiatives to go with it. We have implemented an internal communications plan and have strengthened our DEI committee structure to provide them with resources. A lot of the work has been done in conjunction with the
Network error. That's what I got. My apologies. Gonna have to cut it short. Can you all hear me? No.
Yes.
Okay, I'm gonna see if I can share that. Go back to the slides.
Okay.
Can you see the slide?
Yeah, we can move to the next one.
Okay.
In closing, we'd like to share this quote from a board member from Christian Living Communities. I'll give you a minute to read it before we field your questions. Thank you.
All right. My apologies for that little glitch there with Lorena. Thank you to our panelists and presenters, and we welcome any questions.
Thank you. I really wanted to applaud the efforts of the Tri-County team as well as our panelists for your commitment to diversity, equity, and inclusion, and for your very action-oriented strategies. Sounds like a really impressive program, so congratulations. Are there any questions? I guess I'm curious what your timeline is going forward. So it appears as if many of these programs, are they midstream or are they about to graduate? I mean, are you going to be recruiting some new candidates?
Yeah, great question. Thank you. Well, we have a volunteer leadership team, and that includes Maker Housing and HR Choice, and Tanisha, Patty, and myself. And we have committed to supporting this original cohort. Actually, 12 of the 13 will continue and through another year, every other month. So we're going to continue to support them while we search for funding. We have a few different funding opportunities that we're exploring, and the goal will be to expand this project the way we had expanded upon our workplace wellness coalitions. So add additional cohorts and deeper level of support. As far as graduation day, there is no graduation day. I think that's one of the main learnings from this project is that the DEI work is continuous, it's deep, it's challenging, and you just, it never stops. It's such important work, and we're all learning along the way.
Great. Julie Shills.
Sorry?
I echo Kaya's thanks for everyone joining us tonight. I was curious a little bit about the evaluation, wondering the methodology used, and if there may have been any suggestions, since it was someone who's an expert in the field, about how the program could be enhanced.
Yes, definitely. So one of the big things that he cited is that it would be great to have more one-on-one support. So we didn't have the capacity to provide one-on-one support. We have put together a full proposal for funding, which does include DEI experts originally in each of our counties, Adams and Arapaho, to help provide more one-on-one TA for the participants. And I'm trying to think in terms of other suggestions. He himself was a DEI educator. He works with employers. He also has a background in learning curriculum. So he really gave us a good, we were concerned about the assessment tool. We wanted to make sure that that it was considered, par on par, and he was actually very impressed with the assessment tool. He thought it was a great working document. He suggested that we add a tab to it so that the planning could be kind of put into the actual tool, which I think was a great idea. There were some other suggestions as well, but that was the main thing.
Thank you.
Dr. Faywell.
Yes, thank you. Very nice presentation. My question is about the challenging workforce issue that we have nowadays. Everybody's got a now hiring sign out, and I'm wondering how that affects diversity. If I just throw that out to anybody that wants to answer it, but it seems that it's going to be difficult to be diverse if you can't get anybody to apply.
Well, I can just speak to as far as best practices, and then perhaps Amy might be able to speak more from the employer perspective. I think part of the story in the past is that we would like to have more diverse employees, but they don't apply. And in fact, it's really incumbent upon the employer to look in non-traditional places to explore linkages with school programs and higher education programs and other areas where they haven't been looking. So just putting posts on the traditional, I'm trying to think of, can't even think of it. I haven't been looking for a job in a while, which is a good thing. But I think MAME, I know our HR division has been doing more widening our net, so to speak. And if Amy's still on, yeah, you are. I'd love to hear your perspective on that, Amy.
Yeah, I'll echo Michelle. Having a more diverse workforce is what we're striving towards. It makes us a better organization. And so having that commitment and really being an organization where everyone feels like they can belong and be their best and do their best, that just helps us attract more applicants and more employees. And so that commitment to diversity is so important in terms of recruitment. Just looking at different recruitment sources and how we recruit can help us reach different applicant bases so we can get more candidates and really get the best employees. So we've been partnering with schools. We've been looking at our job postings to encourage folks who maybe have most of the skills, but not all of them, apply anyways, right? We can train a lot of different things. We've been partnering with different community partners and organizations. As part of this, we asked our team members, what can we do? And so utilizing their suggestions to attract more talent as well. So just really looking for different places to find folks who might not have thought about senior living has been really helpful.
Michelle, I'd like to also just jump in as a new business owner that hasn't started doing it yet. I have a detailed accounting of notes of make sure you're posting it in multiple languages. make sure that your language is a different frame from what I've been brought up. My professional background is as an architect. So like change the way in which you're doing things. I've learned like don't ask for resumes and just little things that I would have not thought of during this, like prior to doing this pilot. I now have written down those things so that when I do make a job posting, I'm making sure I'm attracting talent from the community and that's more diverse and equitable.
Thank you, Amy and Katie. And I think Mame, you had your hand up as well.
I just wanted to share an example that I actually can't take credit for. Jill needs to take credit for it, but she had several WIC educator positions open, and we were getting really not the candidates that she needed. So she sent out a flyer and a message in Spanish and English to all our WIC clients and received a great, a really good group of candidates from that. So out of the box recruiting is absolutely the way to go. And the reality is in some areas, there are not enough diverse candidates. Absolutely. Nursing is one of those. So there's really the how to get around that is we need to have more scholarships and more getting a trail of diverse nurses in the schools.
Thank you. Thank you for this really informative and impressive program. I thank you for the panelists for joining us tonight. Dr. Douglas, did you have something to say?
Yeah, I wanted to thank Michelle for putting this together. I'm particularly struck by the fact that this sort of was an organic need identified by folks we were working with, not some cool idea that we cooked up and tried to sell people on. I really am appreciative of our panelists from joining us. I want to thank our board members for suggesting a couple of months ago that we sort of do panels like this. And I think it really does enhance understanding. So really appreciate you all both being involved in the program as well as spending your time to join us. So thank you very much.
Thank you.
Thanks again. Well, we'll move on to the next information item. Wendy Nading is going to share with us an update on access to mental and physical health care services, which is, as you know, one of the objectives in the Public Health Improvement Plan. Wendy.
Thank you. Can I first just get confirmation that you're not seeing my presenter slides, just seeing the slides themselves?
Yeah.
Okay, great. Thank you for your time and today's agenda to provide an update on the access to care priority area of the Public Health Improvement Plan. Our executive sponsors are Penny Grandy from our nursing division. She's our director, and then Heather Baumgartner, our community health promotion division director. My name is Wendy Nading. I am the access to care nurse manager and the co-lead of this priority area. My other lead is Rebecca Rapport. She's a program coordinator in the nursing division. She supervises the health enrollment team. Our remaining work group members are our two regional health connectors, Laura Don, she's the regional health connector for Arapaho County, and Greta Macy is the regional health connector in Adams County. Just also wanted to mention in this work, we align very closely with Tri-County Health Department's maternal child health team in our work, as well as two areas of the FIP, the food and health work group, as well as the mental health work group. We have two goal areas in the access to care area of the FIP. The first goal area is to increase coverage. We do focus on Medicaid, Child Health Plan Plus, and Connect for Health Marketplace plans. And then we have a second goal, which is to increase primary health care visits. As we move through the remaining slides, our work will be presented by project area related to these two goals. In our first project area, it may be helpful to provide a bit of background. The work group members carrying out the work are outlined in this area of the FIP. We were all fully activated in the response until July of 2021. And collectively, we observed and learned a lot, and we're deeply appreciative of the opportunity to be activated. And we realized as we were deactivated that much of what we learned could inform our work in access to care. So really beginning in July, once we were all fully deactivated, we spent the next few months really reassessing the landscape of healthcare access in order to prioritize the projects, activities, and partners that we would work with through the end of 2022. So we reviewed lots of data during this time and we met with many partners. And so we prioritized project work that really would address in some way the major trends outlined on the slide. And the very first one being there's significant concern that many of our community members that are now currently covered by Medicaid will lose coverage when the public health emergency ends. The second trend is that delayed care during COVID, combined with workforce shortages, are placing severe strains on primary care providers. Declines in mental health and severe workforce shortages in this area of healthcare have also had a huge impact and really caused a second healthcare crisis alongside COVID. Community members are struggling to pay for healthcare and prescription drugs, especially given the impact of our economy on those costs. And then to end on a positive note, our use of phone or computer to access services really does offer opportunity for improvement in access. The next 3 slides will highlight data to support the trends on this slide, and then we'll move into project areas and provide an update on those. I did want to thank Callie and the PIM division for help in preparing these next 3 slides. This slide shows the increases in Medicaid enrollment since July of 2020. The graph in blue shows Adams County and the graph in red or orange is Arapaho County. Much of this increase is due to the locked-in provision that was allowed during the public health emergency. So no member enrolled in Medicaid has been disenrolled since the beginning of the public health emergency. But once the public health emergency ends, many community members will need to take action in order to stay enrolled, or if they're no longer eligible, they'll need to seek coverage through Connect for Health or their current employer. This next slide shows that the primary reason people go without care continues to be cost. This slide has a breakdown in different areas that from, if you're going from left to right, it's prescriptions followed by doctor visits, specialty care, and then dental care. The darker vertical line is cost and the lighter green bar is any other reason. Adams County again is on the left of the screen and Arapaho County is on the right. The final slide on data is on self-reported mental health outcomes and behaviors in 4 categories. And the vertical bars, again, going from left to right, are capturing information about difficulty getting care, people that are reporting poor mental health, people that report talking with a PCP about their mental health, and then needing but not getting mental health services. And again, Adams County is on the left and Arapaho County is on the right. The next series of slides will present the different project areas we are working on in response to these trends. This is work we will be conducting through the end of 2022. The written report in the Board of Health packet that accompanies this slide deck lists the major milestones we've already accomplished in the project work I'll be going over, as well as milestones we anticipate accomplishing by the end of 2022. So the next project area that we want to highlight is our Health Alliance work. And a major mechanism of our collaborative process in the area of access to care is through the infrastructure of health alliances. Health alliances are in place across Colorado, and they basically bring together healthcare and healthcare adjacent partners to build relationships and strengthen connections across partners. I'll go into a little bit more detail about these different alliances. Aurora Health Alliance has 310 member organizations, 14 of which hold a board seat, which includes Tri-County Health Department, and average between 4 and 6 work groups at any given time. Over 200 organizations participate in those across those work groups. Currently, Tri-County Health Department chairs 2 of those work groups. One is the Behavioral Health Work Group, and the other is the Kids Work Group. Adams County Health Alliance is made up of 56 organizations. It also includes a leadership group via a steering committee that includes 10 organizations. We convene and facilitate both the Adams County Health Alliance and the steering committee of the Adams County Health Alliance. We also work closely as a regional collaborative, which we term the Metro Area Health Alliances. And this includes health alliances in Denver, Boulder, Jeffco, and Douglas counties. And then there's also a statewide network of health alliances that we are a member of. The third project area that I'll speak with you about is the support we are providing to primary care practices through our regional health connectors. The Regional Health Connector program is unique because it is based on a health extension model that we have seen in other states that provide external support to medical practices, diffuse innovation, and share common resources, including local expertise, coupled with technical resources that can be provided by the university, health departments, and social services agencies. We receive grant funding from the University of Colorado Department of Family Medicine to provide direct support to practices. An example of this work, to just give you a concrete real life example, is our recent work with practices where we were acting as an extension of the university to disseminate information and technical assistance to practices specific to monoclonal antibody therapy for COVID-19. In Adams County, we're currently working with 12 practices, and in Arapaho County, we are working with 14. Those practices are generally large practices that have a significant portion of their practice population as Medicaid community members, which include our federally qualified health centers. Our next project area is to increase enrollment into Medicaid, Child Health Plan Plus, and Connect for Health. Our current activities in this area is we are in planning meetings with Connect for Health and with Connect Aurora to become a funded Connect for Health assistance site. We've been encouraged to apply for full funding through an application process that begins in March for a start date of July 1st. We applied and received funding for a grant from the Blueprint to End Hunger to increase co-enrollment into SNAP, WIC, and Medicaid. This is in partnership with the FIP, Food and Health Work Group, and the Nutrition Division. We have significant work ahead related to assisting Medicaid members with staying enrolled in Medicaid as a result of the end of the public health emergency, and also with some significant changes coming to Medicaid that will require every enrolled Medicaid member to renew through a physical signature. So that is a big change from previous years where if you had no changes to Medicaid, you did not have to return anything by mail. And in 2022, you will have to return something in the mail to Healthcare Policy and Finance or complete that process online through the PEAK system. And we continue to provide application assistance by phone. We have 2 FTE providing services through Tri-County, in addition to co-located staff with Connect Aurora offering Connect for Health Marketplace Insurance access. And also we have an Adams County Human Services application specialist who is embedded in our team. The 2 FTE that are employed by Tri-County, we assisted close to 900 individuals with new coverage in 2021 and close to 1,500 individuals with maintaining their coverage. So that's close to 2,500 individuals we supported in 2021 with 2 FTE. And a lot of the gain in that number was related to that transition from in-person services to being able to provide services over the phone. Our 5th project area is to strengthen local, state, and federal medical assistance programs, which include Medicaid, Child Health Plan Plus, and Connect for Health. Through policy, engagement, and advocacy work, we feel very strongly that we are in a position to inform this policy and systems level work because we listen to the Tri-County Health Department staff that share stories from the families they serve about the barriers they face. Our policy focus areas include a focus on Medicaid, and we do that work through advisory positions at the Colorado Department of Healthcare Policy and Financing, which covers state and federal policy, and also Colorado Access, which is our regional Medicaid agency. We also focus our policy and advocacy work on enrollment, and we do that through covering kids and families, on healthcare reform in general in Colorado through the Colorado Health Policy Coalition, for refugee and immigrant health through the Colorado Center of Excellence in Newcomer Health and the Coalition for Immigrant Health, And then also we focus on dual enrollment through the Colorado Blueprint to End Hunger. In many cases, we hold leadership positions in these forums, either as a voting member or as a chair, oftentimes. To give you a sense of how busy we are in this work, from July of 2021 to December of 2021, we completed over 50 policy and advocacy activities. An example is we are participating in an Update Your Address campaign for Medicaid to really get the word out that folks need to change their address in the system so that they can receive this mail that they're going to get from healthcare policy and finance that they will have to sign and send back in order to stay enrolled. Many of our families move multiple times throughout the year, so we're all very, very concerned about this paperwork making it to the right physical address to keep folks enrolled. The final area, no, I believe we have two more areas. Project 6 is focused on improving behavioral health access by supporting the Behavioral Health Recovery Act of 2021. We did receive grant funding in September of 2021 to implement specific project work in Adams and Arapaho counties. This is again through the Regional Health Connector program. In Arapaho County, this work will include building new referral relationships and processes between providers. And we anticipate partnering with an additional 20 practices in Arapaho County through this work. In Adams County, this work includes funding and implementing peer supports for Afghan refugees, including a partnership with Muslim Youth for Positive Change, which is a community-based organization that serves Afghan families in Adams County, and also partnering with Clinica Family Health, which is one of our federally qualified health centers in Adams County. Just to make a link to a previous slide, Clinica Family Health is one of the steering committee members for the Adams County Health Alliance, and Muslim Youth for Positive Change was highlighted in a recent Health Alliance meeting. And so we made lots of connections to organizations that are part of Adams County Health Alliance by being introduced to Muslim Youth for Positive Change, which is an amazing organization. Our last project area is to increase consumer knowledge on cost and affordability to better inform healthcare decisions consumers make. We intend to do this work by collecting, there are vast resources, if you look hard enough, out online to really help consumers make choices about their healthcare. We are collecting those resources, simplifying them when possible so that they can all live on one consumer-facing webpage. We secured a master's student from the School of Public Health who is providing 120 hours of capacity work on this project. And alongside that, we are also conducting policy and advocacy activities related to relevant legislation in this area. An example of that is House Bill 21-1198, which is advancing the fight against medical debt in Colorado, which is really strengthening the resources that consumers have if they've been to the hospital and receive a bill. And finally, I wanted to end with thanks to Kelly to just helping me think through this slide. But we did, last year when we came and presented to the board, we really did speak to you about what working and being inactivated in COVID was, how that was impacting our work in the Public Health Improvement Plan. And it feels like the shift this year is what is the impact from Tri-County's road to the future. And so did think through a few last bullet points to share with you. Starting off with a really positive one, we have high performing staff who are passionate, informed, and well positioned to continue working with trusted community partners to advance this area of the Public Health Improvement Plan. Some of the challenges, it's really diminishing feasibility to pursue longer term funding opportunities when we are otherwise and often the best applicant for that funding. And oftentimes our people are reaching out to encourage us to apply, and given the current transition, we may not be the best applicant anymore. Stewardship considerations for the backbone support role we provide in many community collaborations. Adams County Health Alliance is a great example of this backbone community support. Greta Macy, who leads that work, probably spends about 0.2 of her FTE or 0.25 of her FTE on that Health Alliance work. And so what will happen to the Health Alliance if Greta is not able to provide that capacity? And finally, stewardship considerations in accepting multi-year competitive and high impact leadership positions on advisory boards and in work groups. We're very involved in that space. And as we continue to be invited and apply, we get questions about, how long are you going to be able to make a commitment to do this work? And so those are the things that we're thinking about as we continue to do this work in the Public Health Improvement Plan. Hopefully there's still time for questions. And I do have the work group members on the phone in case they are better positioned to answer any questions. So Ronnie, now would be the time to invite them to join if certain questions come up. So happy to field some questions.
Thank you, Wendy. What an impressive array of activities. I'm just curious, are you assuming then over the next year that these will still remain the tasks that will be your main focus? Or I know the community health assessment results are coming in. Is that informing your work? Are you reorienting to any particular directions, especially as we start to see the continuing impact of COVID?
I do feel like I appreciate the way our public health improvement plan is designed to be really a working document, a working plan. And so it's very common that we are going in and adding work or closing work out. That's fairly constant. And so an example of that is this change your address or update your address campaign is fairly recent. So we just have added that work into our public health improvement plan. So as the public health emergency, is now slated to end in April. So, pivoting to really focus more capacity if and when it finally does end. We do have the ability within the plan for it to be flexible to add work or really redirect work if we're no longer the right partner to lead that work, or there's an opportunity to transition that work to a partner that may have a bit more longer term sustainability to do that work.
Great, thank you. Any additional questions from board members? Rosanna?
Hi, thank you, Wendy. I had a couple of questions. I wanted to know where I don't see noted is how do we, or Tri-County, help members of the LGBTQ&I community access effective and positive healthcare?
That's a great question. And I'm going to not recall the legislation, but we have already attended a number of policy sessions. We are the first state in the nation to cover services for this population, to include mental health counseling. And so we are very excited and working with Medicaid to understand what those covered benefits will be, and then to get the word out for where folks can access those services, which providers are encouraging of providing those services. So we're very excited about legislation coming to Colorado this year, and really proud that Colorado is the first state in the nation to do that. And I apologize, I don't have the legislation. Maybe Melissa Sager, who's a whiz at knowing these legislations, but it's very exciting. And we are already partnering with One Colorado to get the word out about that legislation and how to be more involved in that legislation. And that is an example of a policy or advocacy action under one of our project areas that we're tracking and participating in.
And for those folks who are not Medicaid eligible?
Yeah, so this is only for Medicaid eligible folks, but encouraging that other health plans might look at how to do that in their health plan. And I think we'll learn a lot about the provider community and which providers are really encouraging of including those services as a provider. And Laura,
do we have anything else to address the needs besides those that are Medicaid eligible, or looking to what there are some practices that specialize? We have nothing else to help those folks
I
access?
mean, I can give examples of where we have reached out. A lot of the services are still virtual, and that has been cited as a barrier right now. This is definitely a population around mental health that we'd like to see those services happening in person again in our school districts. And so we are regularly checking in with our community-based organizations on when those services will start back up in person and trying to spread the news about that. I don't know.
Primary care?
In primary care, a lot of these particular services, especially around youth, have generally been in the school setting in the past. And so that's where we've been continuing to work with our school districts to find out when those groups are started back up and to help to connect youth back into those groups.
For a young adult population that's past secondary school and still needing to access services, that's one area I know that I wanted to see more from Tri-County, from us, to how do we help those folks receive quality primary care and preventative services.
I would say one of the limitations of the way our public health improvement plan is currently set up for capacity is there's a lot of great work going on in other teams that just aren't on this call. A great example of that would be Lauren Mitchell, who's a nurse manager who leads up our HIV team and is out doing a lot of work on the ground. And so those kind of folks aren't on the call where I would normally pull them in and say, can you help provide some of the great work we're doing in other areas? So our team is pretty limited to the advocacy and policy piece, but many of our other programs are doing services, and I'm just, it's hard to stay updated on all the great work. But certainly,
thank you.
Could compile some of that other work if that would be helpful and get back to you on where some of our work is happening across other programs.
Yeah, I'm particularly interested to what's going on with what I hear for the North Aurora area too, particularly with mental health services being underserved. The North Aurora, which is on the Adams County side.
Well, I will definitely. Oh, Penny has her hand up.
Yeah, I think another place that we're looking at, not at mental health, but at serving the LGBT community is more in our sexual health program. Granted, it's not primary care, it's more of a gap filling service, but we have done a lot more training and inclusivity and trying to be more open to different populations. So it's, I think, Rosanna, to your point, it is a huge need, and we're making small baby steps into it, but there are some programming that we're doing to address it.
Thank you. Dr. Douglas?
Yeah, I just wanted to echo what Penny said. There are efforts, Rosanna, going on in other areas, but I think your question is very spot on. Let me remind the board that the Public Health Improvement Plan took upon itself some very ambitious areas identified with the community. Never, ever, ever with the idea that we were going to fix everything. As you heard Wendy say over and over again, we have very little county funding supporting this. This is mostly grant-based funding of various kinds. And the team has been extraordinarily, I think, nimble at identifying funding to support areas that align with the Public Health Improvement Plan and overall agency priorities. But really, there are unequivocally tons of areas that are probably not being as effectively and efficiently and broadly assessed and addressed as we would all like. I guess I'd also like to note the obvious, the gorilla in the room that Wendy kind of hinted at, which is the uncertainty of our transition is creating, or is already creating, and will continue to create challenges with the folks doing this really excellent work. I think what Wendy outlined is really a terrific example of where, when you go read public health statute and say, what's a health department supposed to do? You don't really see language like the work that they're doing or the work that Michelle did earlier. And I think one of our jobs in communicating with both of our counties who are considering how to plan going forward is just where this kind of work that's not mandated by law, but can be so impactful in the communities fits in. And yet, as you've already pointed out, if it's not done comprehensively, still leaves groups that are not as well addressed as we'd all like.
Yeah.
Thank you. Jan?
Sorry, two things. One is I would just like to mention to Rosanna and the rest of the board that when we had questions, I had questions about seeing all the different work done in mental health and everything in Adams County and Douglas County, and I was really wanting to know more about what was going on in Arapaho. I think if you reach out to them, Wendy and Kelly did a fantastic presentation that they put together just for the three of us in Arapaho County. So if you have, like the thoughts you were expressing tonight, I would say just reach out to them because they are more than happy to give you that information if they don't have it right at their hands right now. And the other part of it that I was going to say was kind of echoing what Dr. Douglas said. I've been observing the Aurora Health Alliance for a while, and so I've seen Wendy in action and others. And I wish the county commissioners were so knowledgeable about the far reach of Tri-County and these leadership positions. And I really feel for the loss these organizations are going to feel depending on what happens with Tri-County. The loss of leadership, if I didn't say that, from Tri-County that they have.
Thank you. Any other questions for Wendy? Wendy, thank you so much for that wonderful presentation. Julie, are you waving goodbye or is it?
No, I'm waving because my hand's up.
Okay, go for it.
It's brown, so it might be hard to see. So quick question for Wendy or really anybody could answer and jump in on this. So, one of the things that I really admire about this work is that you guys are essentially the boots in the ground of getting people access to healthcare, which is like, it's a lot of people like to talk about getting people access to healthcare. You actually do the work. And so one of the things that I'm worried about and something that, maybe it's for future discussion or further thoughts too, is, as we continue to go down this transition, we're unsure what this looks like. Are there things that we could do to try and provide as much stability for some of these folks as our ability to serve them potentially decreases over the rest of this year? Some of these folks are really hard to kind of keep track of anyway. Wendy, you said that folks move around a lot. Once they lose kind of that connection, they have to rebuild that all. So I guess I don't know if it's a question or just a thought of, how do we try our best to keep these folks with, some type of consistent contact, especially if we don't really know where we're going to be over the next coming months. And I know it's more of like a sad thing to think about, but it's also, how can we just continue to serve the best way we can until the very end, and just do our best, and the best thing for the folks that we're working with. So go ahead, John, just that.
Dr. Douglas.
I just want to acknowledge, Julie, you've hit the bullseye of the problem with the transition. And you've got people like, the fantastic work Wendy's been doing. Wendy, by the way, I want to remind everybody, was our Mount Kilimanjaro Award winner last fall, our highest honor. I didn't get to say that to her. It's like an Academy Award, but that's the bullseye problem. And the bullseye problem is accentuated by the lack of clarity that we're currently experiencing. I know you know that. The board was CC'd on a letter that we sent to our commissioners this afternoon about what's happening and what the uncertainty is doing. So I don't think we have an answer except to say it's one of the most important questions that the leaders in both counties ought to be asking.
Thank you. Jan?
Sorry, I just wanted to make a correction when I was speaking about Wendy. It was Wendy and Heather that put that presentation and their group that put the presentation. I am sorry about that.
Great. Well, thank you. Thank you, Wendy, and thank you to the Tri-County team, as usual, for your stellar work. We'll move on now to the COVID update. Dr. Douglas.
Yeah, thank you, Kaya. And Lisa, if you could pull up the slides for me, please. And I'll try to, I know we are a little behind I always make us more behind. I'll try to do that less today and maybe keep us up. Before I start, though, you heard the name Kelly mentioned about 5 times in the last presentation. Kelly, of course, has been a central leader in Tri-County since she joined us to head up the Planning and Information Management Division. She's been the backbone behind supporting folks like Wendy in the work on our public health improvement plan and a whole lot else. I just wanted to mention Kelly because this will be the last time she joins the Board of Health meeting as one of Tri-County's division directors. She, I think everybody's aware, has accepted a really critical position in Adams County to be their public health transition coordinator. We're incredibly sorry to be losing her. But if I were to handpick someone for Adams County to help them, I couldn't think of anybody better than Kelly. So I just want to publicly thank her and acknowledge that she will be making even more impact on Adams County in her new role. Okay, let me go ahead and begin. Next slide, please, Lisa. I'm going to go over quickly because you guys were at a Board of Health meeting not very long ago, not a month ago, actually. A very quick update on COVID trends, where we stand with vaccination, a little bit about the aftermath of the masking situation, as well as just some quick looking forward comments. Next slide, please. This is from a couple of days ago, and these are national data. This happens to be from the Washington Post, and this ranks states by where we stand, both in terms of cases and hospitalizations, and it just accentuates news that I think we're all aware of, which are things are getting better and better and better. And in Colorado, they are relatively better than in most other parts of the country, both in terms of actual cases detected as well as in terms of hospitalizations. Next slide, please. This is to show you, drilling down to the Tri-County and the state level, just how impressive those numbers actually look. Once again, during the entirety of the pandemic, and honestly, in my 40-year career doing infectious diseases work, I've never seen an epidemic curve look like this, where something went up this sharply and so high and so fast and came down so sharply and so fast. Tri-counties on the left, each of our 3 counties in different colors. The state is on the right, very, very similar trajectories. I will note that the slope of the line of improvement has flattened out a little bit. We aren't seeing quite the same linear decrease that we saw a couple of weeks ago or even a week ago. That was honestly to be expected. I don't really think it's due to the lifting of the mask requirement. It could be, but I think that's unlikely. I think this is just what one might see as one burns through Omicron. We're going to still have some stragglers who are probably going to be getting sick and will be detected. Next slide, please. These are looking at age groups, and Adams on the left, Arapaho on the right. Take home is all age groups are declining. And really interestingly, if you look at the rolling average of the incident rates, in the recent time frame, they've almost become exactly the same. So in other words, back at the beginning of the school year, the 6 to 11-year-old kids in orange were going through the fall having higher rates than other groups. When we went into the Omicron surge, we began to see it in the older groups in Adams County and the 12 to 17-year-olds in Arapaho County. And now they've just all converged together and going down with very, very similar rates. Next slide, please. I show you guys these maps periodically, and these are on the state's website, and you may look at them. These are the old dial case rates by county, color coded. Red's really high, green's really low, orange is next to the highest, and yellow's in the middle. This shows you where we were the day after New Year's, just as Omicron was taking off. Both of our counties were red, but most of the state was not. This shows you where we were on January 10th, which was the peak of Omicron in Colorado. Virtually the entire state was red. And this, the final graph on the far right, not graph, but map on the far right, shows you where we are as of a couple of days ago, where the colors are getting a whole lot less red, certainly across the metro area. We're all in the yellow, less than 300 cases. It's also worth noting that some of the few counties that were not red back in the middle of January, particularly on the Eastern Plains, have all turned red. Omicron is working its way through the state and leaving lower rates in its wake as it passes through. Next slide, please. These are the state's summary data about variants of concern. Key point is the obvious point. Omicron is pretty much the entire game at this point. There's a little tiny sliver of Delta, about 1%, but basically, by the time these data were pulled together, it was mostly Omicron throughout the state. That appears to continue to be the case. Next slide, please. I will mention that there are other variants of concern that are being talked about. Omicron subvariant BA2, the original Omicron variant's BA1, has been identified in Colorado. I think there are now 3 detections so far. These are slides from Dr. Hurley a few days ago. But it's nowhere near like what's happening in Western Europe, where in a number of different countries in Europe, it's become at least a high plurality, if not a majority strain. The UK Health Security Agency pulled together some information about BA2. I hope it's not going to become a household word like Omicron, but what we know about it is it's probably somewhat more contagious than the BA1 variant we've been experiencing. The estimate is it's somewhere between about 20 to 30% more contagious. In household situations, the Brits observed about a 13% higher household transmission rate. These are very small numbers, but it appears that vaccine effectiveness, this is really a critical issue, are going to be similar, maybe even better. And that's largely based on the hypothesis that because the spike mutations in BA2 are actually more closely allied with the ancestral virus, that's the one we used to call Wuhan, that it may be more responsive, since it was that strain upon which the vaccines were based. I don't know whether the data on the right is going to emerge as anything, but there's a new subvariant of Omicron that's been detected in national genomic data trend sequencing. This is called BA1.1. That's the purple stuff on the graph on the right. The turquoise stuff in the graph on the right is Omicron BA1. And you can see if you sort of split it out, this BA1.1, about which there's very little biologic information that I've been able to come up with, actually is now, at least in North America where these data are represented from, probably replacing the original Omicron BA1. I think this is mostly inside baseball kind of stuff of interest for virologists, because I don't think we've seen an implication of this, but it is to show you something, number one, about how variants will come and go. And if BA 1.1 does end up, becoming a bigger issue, I just wanted you to be aware of sort of where we think it fits in. Next slide, please. Hospitalization, metrics of greater severity, Tri-County on the left, state on the right. Very, very similar trajectory to what we saw with cases. Super rapid increase up, super rapid increase down, all 3 of our counties. The downward slope we're seeing is exactly what we're seeing at the state level. We've now got fewer folks in the hospital statewide and also in Tri-County due to COVID than any time since October. So we're not back to the pre-Delta days, but we are clearly improving. And as the little icon or infographic in the upper right shows, the vast majority of those currently hospitalized do remain among the unvaccinated, 66% as of the 7th when these data were pulled off. Next slide, please. And these are those currently in the hospital. I think the data on the left from the state, these are hospital censuses, is probably a little more accurate because our data do tend to lag a little bit. But as you can see, currently hospitalized patients are down near the pre-Omicron level and getting pretty close to being where we were in late September. Graph on the right shows you what's going on with percent of our hospital beds in our counties occupied by COVID patients. We got as high as about 27%. We're now down to about 17%. And again, you can see once again the shape of that line, the degree of decline looks so similar to the hospital admissions in the case data that I showed you earlier. Next slide, please. This is data from the North Central region looking at the ICU bed capacity on the left and looking at hospitalizations on the right. I show you the North Central region because that's the region we were following for our indoor mask mandate metric. And as you can see here, finally, over the last 4 or 5 days, for the first time, we are consistently just around 10%. And actually, these are data from 3 days ago. As of today, we were at our 4th day in a row of greater than 10%. So we're finally slowly getting out of the woods in terms of the ICU capacity issue. Still tight by historic levels, but improving. Graph on the right shows you all hospitalizations due to COVID, COVID persons under investigation or recently discharged. And that graph is even more impressive where that as of, I think this was on the 7th, 552 persons in the North Central region with COVID or this is actually confirmed COVID. We're now down to levels, again, very similar to what we saw in early October. These are all telling us the same story, honestly, but I'm showing you this because they help us sort of triangulate and confirm that what we're seeing in our counties probably represents overall reality. Next slide, please. These are interesting data that the School of Public Health Modeling team provided us this week. This is looking at declines in something they're calling the admission to cases ratio. What % of all cases get hospitalized? And this goes back to, I guess it's early 21, February 14th, early 21, about a year ago. As you can see in the 3 lines there, the orange is 65 plus year olds, green is 40 to 64, and blue is 20 to 39. Once we got into Omicron territory, we began to see especially in the older folks, a very marked reduction in the % of all cases requiring hospitalizations. This is once again confirming now at a very large population level, the fact that Omicron, while it has made plenty of people sick and put plenty of people in the hospital and killed plenty of people, estimated nationwide, I think you're probably aware, 500, rather global, 500,000, US-wide, 100,000. It's still been a less severe variant to be dealing with. Next slide, please. So let's turn to vaccines. And, I want to focus on the graph in the middle where we show you the histogram. It's all 3 of our counties. And again, just over or under a year ago in April is when we were really rocking and rolling on vaccinations being given. And honestly, as you can see, we don't see a downward trend as sharp as the Omicron downward trend on the right side of that histogram, but it's getting really, really low. So in other words, the vaccines we're giving out are, with each passing week, less and less. And while for Adams, the overall vaccination rate of 84.5, completed vaccination rate of 76.3, and boosted 45.8, in Arapaho 83.6, 76.9, Arapaho 50, boosters 50.7. Those glasses are pretty full, but the glasses are not getting full very fast. And we really do seem to be running into, among the not yet vaccinated, just a wall. It's just really hard to get that last 15%. We do have some who got the initial dose, maybe about 10%, who are still slowly getting that second dose. And then finally, frankly, in some ways, most disappointingly, the booster rate is no better than 50%. And again, this is not everybody. This is only people who are eligible for the booster. These are people who believed enough in the vaccines to get the first 2 doses. And we just can't get the booster dose increased, in spite of the fact that the data just suggests so strongly that, especially against serious illness, being boosted provides you a tremendous amount of added value. I also think it's concerning because when I think about, ending public health restrictions, really good that we did that. I think about moving into endemic. I really believe we are. Keeping up to date with vaccinations at a frequency that's recommended, and potentially even with boosters with different genetic sequencing included, is going to be really part of this. So we're really, I think, looking at the current booster challenge as a learning lesson. What is this? What are the implications for living with COVID if we're having trouble getting more than about 50% of eligible folks actually brought up to date? Next slide, please. these are data that the modeling team also provides us. I've shown you guys the data before, and I just want to say that whether one's looking at cases or hospitalizations or deaths, there remains a very direct correlation. The correlation is actually strongest the more highly vaccinated a county is, the lower the death rate than it is for anything else. And I think that's really confirming that notion that the vaccines, while they may allow some breakthrough infections, are much less likely to allow breakthrough hospitalizations or breakthrough deaths. Next slide, please. So these are Adams, Arapaho, and also Douglas County data looking at it by age group. Alex Kellogg, who's been really doing a fantastic job working with partners in the community to try to focus on a number of different groups. Group number one is those who've never gotten a vaccine. What can we do better to get them vaccinated? Group number two is there's those that are eligible for boosters that haven't been. Group number three are folks at each end of the age spectrum. And what I mean by that is that we'd really love to see the vaccination rates in our youngest kids, currently only 25% completed in Adams and 35% in Arapaho, and in our middle and high school age kids. Again, they're higher than in the younger kids, but they're lower than we'd like to see. And in those kids who could have been boosted, you can see that the booster rates are even lower. The other end of the age spectrum remains really important because that's who gets sick. That's who goes into the hospital, and that's who dies. And while a 93 and an 87% in Adams of initiated and completed is great, and 97 and 92 of Arapaho is great, only getting in the mid 70s of those boosted who are eligible is less than great. So once again, looking at both ends of the age spectrum, the kids, because we think that's going to be what makes school able to operate as safely as possible without mandatory masking, and the older people, because they're the ones at greatest risk. Next slide, please. Now, I'm sorry these are so tiny, but what I'm showing you here are rates of vaccine initiation by race, ethnicity in Adams and Arapaho counties. We've shown you the slides before. The key point here is that we continue to lag, particularly among Hispanic residents. The purple line at the very bottom, which I really apologize, is so hard to see, shows you a very, very slightly improving rate ratio comparing vaccination rates in Hispanics to whites. And back in the springtime a year ago, that rate was above 2. It got better over the summer and the fall, and it's improved to about a 1.5 level. But that means we've got 1.5 times higher vaccination rates among whites than we do among Hispanics. The graph on the right, or not the graph, but the figure on the right shows you state data. And I'm showing you this at 2 levels. The state, I just learned the other day, includes information based on race ethnicity, because the uptake of race ethnicity includes a lot of missing data that includes both the reported race ethnicity, so focus in on Hispanic folks at the top, statewide 38.7%, with modeled race ethnicity in the bottom. Hispanic actually comes up to 47%. That's largely because of the imputation, and it's an imputation, one can't say this is absolute truth, of missing data. That's the group who increases the most with the modeled data. But even with the modeled data, that 47% compared to the 81.5% of whites, again, these are statewide data, shows you that we really do continue to have a major disparity. This is something that I know Alex and team are very interested in. We had a conversation with the state today. We're trying to get county-specific data to look at how our county disparity rates compare to others, to see if we can figure out areas that are doing better and we can potentially learn from them. Next slide, please. I think everybody probably heard about the event at a high school clinic where we were trying with Jogan Health, one of the major contractors, giving vaccinations to do vaccination clinics. Turned out to be a setup. A father sent I think 2 kids in who lied about their age with an attempt to try to embarrass the school and get the clinic shut down. The answer was it was a setup, but they were successful. The clinics were shut down. and the Littleton public schools are not going to be offering school-based vaccinations for a while. It got so bad. Frankly, part of the issue, I think, was the extraordinary intimidation. This was a piece that just came out 2 days ago about the Littleton school superintendent getting death threats over this setup situation where kids went in and lied about their age who actually didn't get the vaccines. Next slide, please. I want to spend a couple of minutes talking about our efforts to enhance vaccine uptake. Equity remains at the top of the list. We've continued to focus on community collaboration to increase rates in neighborhoods that have been lagging: Brighton, Federal Heights, North Glen, Thornton, Commerce City, North Aurora, Sheridan, Inglewood. As I've already noted, we have made progress, but we have not resolved the disparity. And a revisioning of our strategy is underway now. I'll talk about more of that in just a second. Again, our current priorities is anybody without a complete COVID-19 primary vaccination series. Among the many things we're trying to do are gift cards to try to incentivize vaccination. And beginning in March, we'll be offering these at fixed community testing sites and promoted at key large sites across our communities. Likewise, also focusing on children, really trying to get our school vaccination partnerships going. Obviously hit a bump in the road with our Littleton public school partners 2 weeks ago. We've had a very successful youth vaccine ambassador program at Eagle Crest High School, where youth really work to communicate to their peers about the importance of vaccination. This is replicating a successful vaccine ambassador program in older adults, and we think this is really a promising approach. We're also trying to develop strategies to educate guardians and reduce vaccine hesitancy to persuade guardians to vaccinate their kids. As mentioned, we remain very focused on older folks, especially those in long-term care facilities and homebound residents. And again, are focusing on those prioritized neighborhoods and priority populations, increasing our vaccine champion team. Next slide, please. What's going to be happening with the refining of our vaccine equity strategy is, first of all, reassessing the data. That's going to be happening over the next 3 to 4 weeks or so, developing data collection tools to try to solicit novel strategies about engaging priority populations, input from our own staff, especially from community partners, as well as snowballing, talking to community partners about other groups that we may not yet be talking to, developing better data collection tools to understand barriers to vaccination, and collecting data from community members at clinics to better understand this, as well as looking for and reviewing data from others. We'll be piloting new strategies in late February through March based on the data that we've been collecting. We'll be engaging new and existing partners in a newly initiated community of practice office hours, where Alex and colleagues will be talking with community members. By the end of March, we want to be prioritizing our top engagement strategies after the data collection period and the piloting has been completed. And hopefully by the end of May, we'll be seeing some progress. Now, I want to make a note that this is a tough situation. I asked the state today, what ideas do you have that we're not using or not doing? And the answer was, we'll have to get back to you. I mean, the state has actually made a very, very, very big equity effort. So this is not like they've been asleep at the wheel. It's just that this has been really challenging. I asked all of our school superintendents on a call we had yesterday, what are you guys seeing and what's the issue, especially in your Hispanic residents? And the answer I got was, it's not access. We've got school-based clinics and our kids don't use them. They want to go to their own pediatricians. We've got a lot of other folks who are frankly afraid to write their names down in places that could be in a government system. So this residual fear that we know has been an issue, at least from 5 superintendents I talked to yesterday in both of our counties, is a very real and ongoing problem. Next slide, please. And I just want to highlight some of the nice work that Becky Gwen's team's been doing with our communication work. We're working with the Metro Denver Partnership of Health to create communications for new vaccine eligible age groups, reaching out to health equity partners on vaccine marketing. Pictured on the right are some of our vaccine champions. Becky's team has got a draft video that I was tempted to send out to you because it's really cool. It's 2 minutes, it's short, and it shows these folks in action. They're very impressive, but it's not finished yet, so you'll get it when it's finished. We're partnering with Boulder County Public Health to get information from the BIPOC community about vaccine hesitancy. We're increasing Spanish radio ads for clinics in Adams County, social media ads for clinics across all 3 counties. The booster ad results for December to January are listed below. For example, 40,000 impressions in Spanish during that time period. Working on special projects with community media outlets, particularly Telemundo, Univision, and El Comercio. Again, trying to recruit more vaccine champions because they have been really terrific. And we will, as I've already indicated, be accompanying the strategic rethinking of the equity work with some new communication work that Becky's outlined using the timeline that's shown on the slide there. Next slide, please. Touching in finality on where we stand with the mask mandates. So this is what's happening across the metro area. I suspect you're reading the news that states across the country are ending their mask mandates, even states that have been, sadly, masking's become politicized, even very blue states that have had state mandates are ending them, New York, California, Oregon, et cetera. This shows you where we stand in the metro area. Ours ended on the 4th, Broomfield's ended on the 3rd. Denver had indoor mandate ended on the 4th, and their school mandate announced yesterday's ending on the 25th. Jeffco Board of Health decided a few days ago, or I think it was late last week, that both of their mandates would end on February 18th. And Boulder, among the metro counties, is the only one with an indefinite plan about the duration. The data I show you on the right really are to highlight, maybe we can focus just on the incidence rates at the top, that while we're still seeing downward trends, the downward trend, as I indicated earlier, has begun to slow down. I do not think it's due to the end of the mask mandate. I think, again, it's mostly due to flattening that we would have expected with a curve that was, or a line that was frankly almost too straight to believe it. But we will be monitoring this just to see if additional messaging or communication is needed. Next slide, please. I do want to acknowledge that I am hearing from everybody, superintendents, folks we hear from on social media. There is lots of confusion about masking. Are we ready to throw them away? What are all these governors doing? They're going against CDC. We're trying really hard to explain the difference between a public health mandate and a strong public health recommendation. And there's often been confusion. And what I'm showing you here is some of the data I think that should help us buttress the why should I bother with a mask. CDC published in the MMWR on Friday some of the best well-performed and collected data on the value of masking, and found that cloth masks, surgical masks, and N95 respirator masks were 56, 66, and 83% relatively, respectively effective in preventing infection. Now, this is not proof that mask requirements or mandates work. I get that. That's a policy, and this is an individual level intervention. But at the individual level, masks really do, and one of the most rigorously performed analyses I think that we've seen, really do provide benefit. With the higher grade mask, more benefit. Next slide, please. And I think we'll close out here. Again, our trends are creating growing optimistic. Even our more cautious colleagues at the state are acknowledging the greater optimism. We've got the vaccine challenges about uptake, equity. There are still conversations about mandates versus voluntary programs, but we're certainly not embarking on those at this point ourselves. Still worried about the boosters, the young children. Also don't want to lose sight about, especially if and when we get new variants that increase rates, the importance of the other ancillary protection measures, masking, ventilation, and potentially facilities requiring vaccine passports. That's not been widely used in Colorado, although it has been in other places. We heard today from a call with the state health department that within 2 months or so, we expect to get much greater access to treatment, particularly the oral drugs. That'll be great. We're currently having to make tough choices about who gets them, particularly Paxlovid, which is the most effective oral medication. To me, one of the big questions is one we talked about in our meeting last week, which is this endemic accommodation. Are we ready? When do we transition? How do we explain this? How do we do this effectively? We all want to do it. We all want it to happen. What's the right rate of speed, and how do we message this in a way that doesn't create further confusion? And then finally, I just want to point out, it was really wonderful tonight to hear from some of our other programs. I know our community has gotten tired of Tri-County being equated in a one-to-one relationship with COVID, when there is so much else going on and there are so many other needs: air quality, chronic disease, impacts of climate change, or some of the social determinants issues exacerbated by the pandemic: food, housing, and certainly behavioral health. And then lastly, I want to acknowledge there was a paper that came out in the Lancet last week that looked at transnational comparisons as to how countries did in fighting the pandemic. And one of the most striking correlations that, frankly, for all the pandemic planners hadn't really been accounted for was trust. Trust in the government and trust of other people. And the countries that ranked lower on that, and the US is not at the bottom, but we are absolutely not at the top of trust in government, trust in public health, or frankly, interpersonal trust with each other. This was called out in the JAMA paper a month ago. I discussed it at the last monthly Board of Health meeting about one of our preparations for future pandemics is to try to figure out what it means to regain trust in the institutions that serve us as well as each other. And I don't have a solution for it except to say that it's something we're deeply interested in, and whether we are Tri-County for the rest of the year or whether we're serving other counties in some other format in the future, I think it's something that all of us interested in the well-being of our public needs to keep in mind. So I will stop there, and I'm happy to take any questions that anybody has.
Great, thank you, Dr. Douglas. Jan?
Yeah, I had two questions, but he already answered the one. I was curious how much and when we were going to see more availability of the treatments. And does that include the monoclonal antibodies, or are they still only saying only one works really well?
Yeah, only one of the monoclonals works. It's in very, 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 very short supply. It's supposed to be getting better. I think Paxlovid, which is far and away the better of the two oral drugs, will become available more quickly, but those supply chain and manufacturing issues are hard to predict. I will say that Evusheld, which is a drug that's given not for treatment, but for pre-exposure prophylaxis for very immunocompromised patients, works really well, and it's being underutilized in Colorado. It's being marketed through infectious disease clinics for HIV patients, oncology clinics, rheumatology clinics, and other places. And so far, we probably are using a lot less of it than we could be. So it's, in some ways, in fact, we talked, this was on the GERP today that I'm a member of today, about how we probably need to be marketing this better to both docs who care for those patients as well as the patients themselves.
Is that like a prophylactic treatment that they would take, say,
it's a monoclonal, Jan, and it's got to be given, I'm almost sure, by sub-Q injection, although it's possibly, I think it's sub-Q injection and not an infusion.
I was just curious how you do pre-exposure, because you don't ever know when you're going to be exposed.
Well, this is really a good thing. It turns out the duration of protection, at least based on the clinical trials that have been done so far, is 6 months. And I asked that question is, should we be making recommendations based on community transmission rates? And the answer is, if we could predict community transmission rates, we could, but we're not expert at doing that yet.
Thank you. And the other question I had was, I was reading through all of these reports and things and seeing that there is a high rate of the deaths still are coming from the 65 and older, especially in Arapaho County, which is what I was paying attention to. I was just curious, does Arapaho County seem to have a higher, what do you call, long-term care population than the other counties?
I don't
there, the deaths.
Jen, I don't know the answer to the question. It's a good one. I don't think Jen Chase is on the call now. It's certainly Arapaho County. You probably remember back in April of 20 just got slammed.
Yeah.
And it's high hospitalization and high death rate was due to long-term care facility residents. But I don't know whether they have higher numbers. I don't know whether you do, Tom, if that's why you have your hand raised.
I was just curious. Thank you.
Yeah.
Thank you, Dr. Faywell.
Yeah, John, I was wondering, could the booster hesitancy in those that have had their two vaccinations be in part due to the fact that they contracted Omicron, got sick, and now they think, well, my antibodies have to be off the chart. And how accurate are the antibody tests anyway?
Yeah, I think that's a really good hypothesis, Tom. We're learning there's more data coming out about natural immunity, and certainly for the short term, it appears to be pretty robust. And I told you guys a week and a half ago that the modeling team had estimated that almost 50% of folks had gotten Omicron. And so I think your question is quite legitimate. Gee whiz, if I got Omicron, why do I need to worry about a booster? The other observation that's been made is that people who got, okay, I'll get these 2 doses. They're really great. I get it. I'll get it. And now I got to get another one. They must not be so good. And so I think we potentially have both things working against us. I do think the natural immunity is important. Again, I wish we had a better way of quantifying the duration of infection, but that may also be part of people's thinking.
Yep. Okay, thanks.
Great, thank you. Any more questions? Not seeing any.
There's one in the Q&A.
Yeah, Renee just pointed me to one in the Q&A. Is the less severe variant description of Omicron just due to how many are vaccinated now, or is it when comparing illnesses? It seems to be both. This is a very good question from Melissa Orowski. It does appear that vaccines are making Omicron less severe, but it also appears that in unvaccinated people, it is also less severe, but not severe at all. And that's, again, who's being hospitalized and suffering the severe outcomes. So thank you for that good question.
Great. Thank you. Thank you for that very detailed presentation. We'll move on now to the Executive Director's report. Lots of really good, impressive information about the activities going on across Tri-County. Do we have any questions or comments about the Executive Director's report? Yeah, Julie Shills.
I wanted to say that there's a lot of impressive updates in the Executive Director report, and tapping into what we heard tonight about, everything that's going on within the staff and all the activity. I was really excited to see the work started related to Tri-County being part of the National Health Equity and Overdose Prevention Mentorship Program. So just wanted to pin that would love as the work moves forward to hear more about that, and because of the equity lens, such a nice opportunity to perhaps bring it to other programs as well. So kudos to the team, and just wanted to do a shout out for that one and express an interest to get more updates.
Interest noted, and I want to thank Heather and her team for, in spite of all the uncertainty, when they see opportunities like this, pursuing them, because we think they can be valuable this year and hopefully in years beyond. So thank you for that.
Right. Thank you. Dr. Faywell.
Yes, under the legislative update, the third bullet down on Senate Bill 22076 was heard before committee today and had testimony. Kim Muramoto, who used to be on the board, testified, I think in person. Not being able to be down there, I sent in written testimony, and hopefully sponsors Holbert and Mullica we'll get that shepherded through and we'll have that passed so that some of the issues we had toward the end of last year will not be something that we'll have to put up with in the future. To have your license challenged simply because you're on a board and somebody doesn't agree with your opinions.
Tom, thank you for speaking out on that. It's quite important, and I'm glad Kim was able to speak as well.
Thank you. Julie Malika.
Really, I just wanted to highlight the HR report. I think that that's really important just for the board to keep an eye on as we continue just trying to get a better understanding of how operations are impacted. And then, John, I do appreciate the email that went out to Adams County commissioners and elected officials. I feel like that's just a really good communication tool and making sure that we're providing transparency through this process.
Thank you, Julie. I just want to make it clear, they did go to both Adams and Arapaho commissioners. They went 2 separate emails, but both heard very similar, exactly the same comments. And I think the suggestion that you've made to me in various conversations, others have as well, of trying to keep regular updates about this going, not just to you and when Maine pulls this together each month, but to our elected leaders.
Great. Thank you. Moving on to other items. In terms of the agenda for the March board meeting, the Board of Health is scheduled to receive a quarterly financial review. And in addition, we'll have our regularly scheduled COVID update. If there are any other topics, you can certainly let me or Julie Mullica know. In the meantime, does anybody have any suggestions they'd like to make before we move on to our next 2 board member remarks? Dr. Douglas.
We can talk with you and Julie about this, but we've got some, we think, helpful updates on air quality monitoring. So I'll just flag that for the whole board to hear.
Great, sounds great. Okay, board member remarks. Are there any remarks from board members? Jan.
Of course. You know, I guess it comes from being a nurse and watching what happened during the pandemics, but I just have a personal plea to the staff and the folks at Tri-County to try to hang with Tri-County if you can, realizing everyone's situation is personal. But I just wanted everyone to know that your presence here or at Tri-County, your efforts and your work is recognized and appreciated, and your impact is immeasurable. And just let you know that. Thank you.
Thank you, Rosanna.
Hi, and ditto on Jan's excellent remarks. I'm just tagging on to that. But what I wanted to know is to include an update on the GEO facility and COVID outbreaks there for the next meeting.
Great idea, thank you. Okay, closing remarks as always, I'd like to thank my fellow board members who volunteer their time in service of keeping the citizens of our region healthy and safe. And thanks as well to the terrific Tri-County team who devote their time and energy to staffing these terrific award-winning programs that we hear about at each one of our board meetings. So thank you. As a final topic tonight, the Board of Health will be moving into executive session in accordance with the Colorado Open Meetings Law. No policies, resolutions, regulations, or rules will be adopted during this session. And as specified, the Board of Health will be considering 2 topics. We will be meeting with legal counsel to discuss Tri-County's transition planning options, and we will be considering Dr. Douglas's performance objectives for 2022. Randy, before we move into executive session, did you want to cite the legal provision that provides for client attorney consultation with the Board of Health?
Yes. In accordance with section 24.6.402, so paragraph 4, we're moving into executive session to first discuss legal questions surrounding transition planning options for the health department. And then the second part is personnel matters concerning the executive director's performance objectives.
Great. Do I have a motion to move into executive session for these two topics?
So moved.
So Julie, do you want a second? It's Dr. Faywell and then Julie second. Any discussion? All in favor, please say aye.
Aye.
Anyone opposed? Motion carries. Renee, if you could just move us into executive session, please. And thanks to everyone for attending tonight.
Sure, will do. At this point, I need anybody who is not on the Board of Health, John, Jennifer, Lisa, to exit the webinar.
Great. It looks as if now we have the team available now for our executive session. Jennifer, did you want to introduce the lawyers who are with us tonight?
I'd love to. Thank you. So I'm excited to add Brownstein, our attorneys, Carolyn White and Sarah Mercer, who have their different specialty areas, but they have been added to our legal team. And it has been very beneficial and complementary to our work with Sid Overton, who is not